Welcome to the Society for Academic Emergency Medicine's Upper Extremity Nerve Block video series. This is the second part, which covers peripheral nerve blocks of the upper extremities. Part 1 covered brachial plexus nerve blocks. Let's begin with a case of a painful, swollen middle finger. This patient presents with a felon. For nerve blocks, the general idea is to block as distally as possible to minimize the risk of adverse events, allowing for the injury in question and the positioning required. You offer this patient a digital block, but he has throbbing pain shooting into the palm, so would prefer something more proximal. A median nerve block would be ideal for this infection. Now we're left to decide whether to approach the nerve in the forearm or above the elbow. For a forearm approach, the patient is best positioned supine with the arm abducted to 45 degrees and supinated. The transducer is placed in a transverse orientation in the midvolar forearm, proximal to the elbow crease. The median nerve is identified running in the fascia between the flexor digitorum superficialis and profundus muscles. Inserting the needle from whichever side is more convenient, the needle advances until adjacent to the median nerve, where 3 to 5 cc's of anesthetic are deposited. The forearm approach is probably best for this patient. In this video, we see the needle approaching the median nerve and then injecting anesthetic to hydrodissect the potential space between the flexor digitorum superficialis and profundus. An alternative is to find the median nerve above the elbow as it runs near the brachial artery. The patient is best positioned supine with the elbow straight and the arm abducted to 45 degrees. The transducer is placed in a transverse orientation over the distal humerus, just proximal to the medial condyle and the elbow crease. The median nerve will be identified as it runs next to the brachial artery and vein, superior to the brachialis muscle. The needle enters medially, away from the artery, and is advanced until adjacent to the nerve, where 3 to 5 cc's of anesthetic are deposited. In this video, we see the needle approaching the median nerve, which is identified by its location next to the brachial artery, and injecting fluid to surround that nerve. Let's move on to our next case, a 23-year-old woman who suffered a fall and laceration to the smallest digit. As the wound extends into the palm, a digital block will not be sufficient. An ulnar nerve block, however, will cover this wound. So again, let's look at the ulnar nerve below and above the elbow. In the forearm, the ulnar nerve is targeted as it exits the cubital tunnel. The patient is best positioned supine with the arm abducted to 45 degrees and supinated. The transducer is placed in a transverse orientation over the proximal part of the ulna. Here, the ulnar nerve can be seen running near the ulnar artery in the fascial triangle formed with the flexor carpi ulnaris, flexor digitorum superficialis, and flexor digitorum profundus muscles. The needle enters from the ulnar side, away from the ulnar artery, and is advanced until it's near the ulnar nerve, where 3 to 5 cc's of anesthetic are deposited. In this video, we see the needle injecting anesthetic around the ulnar nerve, which lies ulnar to the ulnar artery. We can see the flexor digitorum superficialis and profundus. The flexor carpi ulnaris is obscured a little bit by bad contact with the skin, but would lie in this area. Above the elbow, the ulnar nerve is targeted just proximal to the medial condyle before it enters the cubital tunnel. The patient is positioned supine, the elbow is flexed to 90 degrees, and the arm is abducted to 90 degrees. The transducer is then placed in a transverse orientation over the distal humerus, just proximal to the medial condyle and posterior to the brachial artery. Here we can see the ulnar nerve is superficial to the triceps muscle, very superficial overall. The needle is inserted medially until it reaches the ulnar nerve. 3 to 5 cc's of anesthetic are deposited just adjacent to the nerve. Finally, let's revisit our patient from part 1. We performed a shoulder block on this patient to reduce his shoulder dislocation. The arm is now slinged, but we must address his thumb laceration. The shoulder block, unfortunately, will not provide any analgesia to the hand. Additionally, our access to the patient's volar forearm is now impeded by the sling. A radial nerve block will cover this wound nicely without using too much local anesthetic. Let's choose an approach. In the forearm, we will target the radial nerve just distal to the medial condyle. The deep branch of the radial nerve will not be blocked, so the deep compartments of the thumb and the dorsum of the hand will not receive analgesia. The skin, however, will receive the block. The patient is best positioned supine with the arm abducted to 45 degrees and supinated. The transducer is placed in transverse orientation over the proximal part of the radius. Here the radial nerve is seen in between the radial artery and the radius. Inserting the needle from the radius side, away from the radial artery, the needle advances until adjacent to the radial nerve, where 3 to 5 cc's of anesthetic are deposited. For our particular patient, who is in a sling after a shoulder reduction, we will not be able to abduct the shoulder like this. Better then to look for the radial nerve above the elbow. In this image, we'll watch the needle approach the radial nerve from the radius side, away from the radial artery, and then inject infiltrating anesthetic in that area. One more time, we'll watch that. Above the elbow, the radial nerve is found above the medial condyle of the humerus. Blocking this location will cover the deep branches of the radial nerve, which includes the posterior interosseous nerve. This gives analgesia to the deep structures of the thumb, as well as affecting the motor nerves of the dorsal forearm and hand. More relevant to our case, though, is that the patient may keep the arm adducted with the elbow flexed to 90 degrees. The transducer is placed in a transverse orientation over the distal humerus, medial to the lateral condyle of the elbow. The radial nerve will be visualized running in between the brachioradialis and brachialis muscle fascia. Approaching from the side closest to the operator, the needle advances to deposit 3 to 5 cc's of anesthetic around the nerve. This video shows the needle approaching the radial nerve through the brachioradialis muscle. That concludes the two-part lecture series on upper extremity nerve blocks. I'm Josie Valenzuela, and thanks for your attention.